Well, good afternoon and welcome to Cancer Center Grand Rounds. By the way, for those of you seated on the stairs, there's plenty of empty seats. Make yourself comfortable. You might get an easier view of the screen as well. No one needs to sit on the stairs. You're welcome to sit on the stairs, but you can also enjoy a comfortable seat in the auditorium if you like. We're very pleased to have an outstanding speaker today and somebody who I really value as both a friend and a mentor for many years since my early years at the Brigham. Dr. Thomas Lee received his bachelor's degree from Harvard, his medical degree from Cornell. He also received a master's from the Harvard School of Public Health, and having received his training in internal medicine and cardiology at Harvard, really emerged as really an innovator in care delivery and how medical organizations can operate, how they can improve the care of patients. And Tom has done this in multiple ways in terms of how we deliver care to patients who show up to the emergency room with chest pain, to really much more complex questions across service lines and across health systems. Tom has ultimately risen to the level of professor of medicine at Harvard Medical School and professor at the Harvard School of Public Health, and then ultimately became the chief executive officer of Partners Community Healthcare Inc. and the president of the Partners Healthcare Network. And most recently is now the chief medical officer for Ganey. Tom's work in helping organizations deliver care better and to understand how healthcare organizations can run and do their best has been something that has been pervasive throughout the medical literature and in terms of what we know. I mean, he's a frequent contributor to Harvard Business Review. He's on the editorial board of the New England Journal of Medicine and a contributor to a number of other forums that have educated physicians and organizations. So, Tom, we're really pleased to have you.
Thanks very much, Charlie. Well, I'm delighted to be here. I am a good friend of Charlie's, and I'm rooting for his success. And I am an admirer of Yale, but I love healthcare above all. There are two sort of crises that many people think of as separate, but I really think there's a common path forward that I'm going to try to describe to you today. The two sort of crises are the sort of complexity of care has led to patients often feeling like lost and feeling panicked and as if no one's caring for them. And there's a second crisis, which is clinician, doctors, nurses, but frankly, everyone involved in care delivery feeling burnout and the need to cultivate resilience. And then there's this new word that's I've been trying to help inject into the discussion, which is grit. I mean, some of you know the work of Angela Duckworth, the psychologist from Penn who is won a MacArthur Prize and has that famous TED Talk and book on grit. So Angela's my cousin, and we just wrote this article on grit in healthcare that was in Harvard Business Review, and I'm going to come to that. And I hope by the time I get there, you'll see why I think there is a common path for addressing both of these issues. I don't think they're exactly the same issue, but I think there's a path forward that's essential to pursue here at Yale, as well as in the rest of healthcare. Now, I want to start, oops, the wrong keypad. I want to start by showing you something that that makes me jealous. And I mean, Charlie made me sound like I'm a wonderful guy, but I'm not that great. I get motivated by base motivations, and jealousy is one of the ones that I feel most intensely. So here's something that makes me really feel jealous. And I put this out here because there are a lot of young people here in this room. And when I think about what should you do with your lives, I mean, I'm hoping some of you will do something like what this young woman did, Emily Sedgwick. So she is, she actually trained in radiology at the Brigham in Charlie's era, a little after Charlie. And it's not Baylor Medical College, it's Baylor College of Medicine, my fault. And what she's done over the last 12 years is she's taken a lean management approach to reducing fear, not just reducing cost, but to reducing fear for women having breast cancer screening. So if you go to Baylor College of Medicine and a few other places in the country, but only a few, 95% of the core needle biopsies are done the same day after an abnormal mammogram, as opposed to most places. My guess is here is like most places where it's probably the biopsies are done the next day or sometime the next week. At Baylor College of Medicine, the women don't leave the room after their initial images because they don't want to have to call the women back into the room for more images after they've been looked at, because their sense is, they don't have any data, but I think they have common sense. Their sense is that when women get called back into the room and told we need some more images, it scares the heck out of them. And it scares the heck out of most of them unnecessarily. 90% of abnormalities of mammogram are not cancer. And but everyone who gets called back in the room, their heart stops. So they don't do that there. They've done a whole bunch of other things. And the reason that Emily got started on this is that she just thought it wasn't right to take care of patients differently than the way doctors and doctors' spouses were taken care of. For them, they got their biopsies right away. And we knew what to do, but we just weren't doing it for everyone. It took real work. It wasn't just giving a pep talk. They had to get everyone to commit to the goal of reducing unnecessary fear and treating patients the way they wanted to be treated. They had to organize real teams and cross-train the personnel, because you need flexibility. because some days there are no biopsies, some days there are 7 biopsies, and they needed everyone. You needed to be flexible. They couldn't grind to a halt because someone was off for lunch or out on vacation. They needed everyone feeling like we all own this together, and cross-training so that they could plug in whoever to get the biopsies done. It took some management skill, like trying to schedule high-risk patients earlier in the day, so that gave you more window of time in order to do the biopsies. They made a decision that it was okay to have lower RVU production per hour in order to achieve the goal of having the lowest fear breast cancer screening program in the area. They're at the 35th to 40th percentile. They're not the 80th percentile, but they're not the 10th percentile either. And the real reason they're lower is because they actually have radiologists talk to every patient, even the normal mammograms, before they go home. And the overall breast cancer program at Baylor College of Medicine has grown several-fold, because this is where everyone wants to go to get their mammograms done. But the radiologists themselves have fewer RVUs per hour than they would if they went to some place that was just focused on generating RVUs. But they're happier there. They feel really proud. One of the I visited there, and Emily, when she was starting to put the program in place, she told people, everyone here gets lunch every day, but it may not be at lunchtime, because the flexibility you need if you're going to do biopsies the same day. And then she found out that people repeating that, they felt proud. They wanted to think of themselves as the kind of person who would miss their lunch even, so that someone didn't go home and have an unnecessary night of sleeplessness because they're waiting for the next step. Now, there's a framework for thinking about this that, and maybe I'm getting old and soft, but I use TED Talks as my references, more often than in the past. But how many of you know this TED Talk from Simon Sinek? So only one? Okay, 2 people. Okay, this is so much more important than my talk today. You can leave and go watch this. And, it's the 3rd most viewed TED Talk of all time. It came out in 2009, and you probably know the gist of it, even if you don't know the talk. Even though the talk is great to watch. This is the talk that introduced the think about why, how, and what into the lexicon. So you'll hear people say they don't have the right why, or the how's not clear, that kind of thing. So what Sinek was interested in was why do some organizations, some leaders get trust and cooperation and loyalty, and others not so much? And he begins his talk by drawing the 3 concentric circles on a flip chart, which is shown in the picture there. And he puts why in the middle, and he puts how in the next circle out, and what in the outer circle. And he talks about the fact that most people, most companies, most organizations focus on the what. We've got to move more patients through. We've got to fill our beds. We've got to computer companies, we make computers, and they may get to the how, like, okay, we have a better supply chain, we make them cheaper, we make them quicker according to your specifications. But the companies that get loyalty and cooperation, they and the leaders, they go in the opposite direction. They start with the why. And the contrast is obviously Apple in the computer world. Apple gives this message since the Macintosh first came out. Like, there aren't many of you here who are old enough to remember the Super Bowl commercial where they introduced the Macintosh. I mean, how many of you do remember that? Most of you don't. This is sad. But I won't go into other trivia questions to test how old Charlie and I are really getting. But the famous ad that introduced the Macintosh was basically a woman athlete throwing a big hammer through a screen, liberating people who were held prisoner by the IBM world. So, the message from the start from Apple was about the why. We are going to help you think different. We're going to help you challenge the status quo. And the how, well, okay, we make things that are consistently beautiful and intuitive and easy to use. And the what was almost incidental. Like, we make watches, we make laptops, we make iPads, we make telephones, we make cameras. If Apple made a car, I think all of us would be interested in checking it out. But in contrast, what Seneca does is he talks about gateway computers shortly before this. They had tried to go into making flat screen televisions. I mean, they were perfectly equipped to make low-cost flat screen televisions. They were making low-cost flat screen monitors. And so they went to the marketplace and no one bought them, because why would you buy a television from a computer manufacturer? But if Apple were to do something like that, of course, people would be lined up for it. So his point is, the big point is that people give their loyalty and their trust and their cooperation on the basis of the why. He talks about people like my oldest daughter, Simi, who's a medical resident at the Brigham. She is one of those people who lines up outside the Apple store before the new iPhone comes out, not because she needs the phone, but as Seneca says, it's because of the way it makes them feel about themselves. That phrase about, where I'm going with this is like, what's really important for Smilo, for Yale, for wherever you work is, how does that place make you feel about yourself? Does it make you feel better about who you are? And if the why of the organization is one that makes you feel better about yourself, well, then you're going to deal with a bunch of things a little differently. We have actually, I'm sure Seneca had no data when he did this talk. Now, we actually have a lot of data at the company where I work, Ganey, on doctors and nurses and patients. And I can tell you that he's right, actually. His talk is a brilliant one. Doctors and nurses, they give their loyalty to organizations because of the why. If they feel like this is a great place it doesn't have to be a great place, but it has to be trying to do something great that they're proud of, then they have a different attitude toward things. Patients, on the other hand, and I'm going to show you a little of these data, patients actually assume that we have the right why. They assume that we're here to help them. And they give their loyalty on the basis of the how with which care is delivered. And we have a ton of data that basically show, and I will give you a little taste of it, that if organizations like this one get the why right and they get the how right, then patients and also personnel will cut them slack on the what. And I'll give you an example of what I mean now. All right, so this is the first thing I did when I went to Ganey. When I first met Charlie, back in the 80s, I was a young cardiology fellow and cardiologist. I was doing chest pain in the emergency department research, actually with a lot of people from this community as well, Yale and Waterbury Hospital and St. Mary's and so on. And we used this approach called, a guy named Lee Goldman, who's now Dean of Columbia, was the leader of the group. And we studied chest pain in the emergency department, trying to stratify patients according to risk. That's the kind of stuff I was doing when I met Charlie. And I actually tried to actively recruit Charlie into cardiology, but he didn't follow my advice. But the same research techniques, I wanted to use when I went to press Ganey 5 years ago. We had a ton of data on patient experience, on how patients rated their care. And so what this figure is using that same kind of recursive partitioning approach, say what are the drivers of patients' likelihood to recommend. This is a huge database. This one was 937,000 patients. And the variable, the outcome of interest is failure to give a top level likelihood to recommend the doctor or the practice. And as you can see, 15.7% had the outcome of interest, failure to recommend. Now, let me say a little bit about failure to recommend and likely to recommend, because I'm sure that many of you feel the way I do, which is that patients can't tell when they're getting good care. And it's true. I mean, I can't tell who's giving good care outside of my own areas of expertise. And if I'm not sharing care with them, I can't tell who's good. So if I can't tell, how can they tell? But what led to my changing, not just me, but like a whole bunch of my colleagues changing their attitude about were two things. One was healthcare reform came faster to Massachusetts than the rest of the country. 2006 was when we passed it. And we started having to really think about becoming efficient. And the question came up of, what are we trying to become more efficient at? What are we trying to do? We never actually asked that question. And I don't know whether you've actually had posed that question here about what's the goal? What are we trying to do? But if you don't have an idea of what you're trying to do, efficiency feels like it's a political game. What can I cut and get away with without creating too much of a ruckus? The other thing that was happening that I think that in this community you would relate to is my friend and colleague from the Brigham, Atul Gawande, was finishing his book, Being Mortal, around the same time we were having this what are we trying to do discussions at Partners Healthcare. And Atul he came the same question from a different direction, because he was obsessed with the aging of the population. His own father was dying, and I think a lot of you know that book, Being Mortal. And so his epiphany was that we're the first people in human history for whom frailty has become a routine condition. And when people are frail, you have to actually ask, what's the goal? What are we trying to do? Because it can't just be doing evidence-based medicine as well and safely and efficiently as possible. You have to say, what are we trying to do? And so Atul is a good friend of mine. And as we talked about this, the business thing about what's our goal, the moral thing about what's our goal, we arrived at the same place, which is, we want to reduce suffering. That actually is the goal. We want to give people peace of mind. Anguish is a very important type of suffering. And, as one of our colleagues put it in one discussion we had, this was at a business meeting of partners. They said, look, we're all going to die. Most of us are going to go downhill before we die. And we all want peace of mind that things are as good as they can be, given the cards that we've been dealt. And I was running the meeting, and I was, I think a lot of physician leaders think their job is to try to break up the meeting and with jokes instead of like get anything done. And I think I was still in that phase. And so I was just joking, and I said, well, that'll be a great marketing slogan for the Brigham and Mass General, peace of mind as you go downhill and die. That'll really bring people in. But someone immediately said, that is what we're supposed to do. We are supposed to be giving people peace of mind. And I mentioned this at dinner last night with Charlie and Karen and others, because I think that one of the goals here is you don't want anyone to have to leave Connecticut, to have to leave Yale in order to have peace of mind that things are as good as they can be given the cards that they've been dealt. So with that, if you buy that may be the ultimate product because of healthcare. We can't make people live forever. We can't restore them to health in many cases. We have to do what we can, of course. But if we're not giving them peace of mind, we are not finishing the job. So likelihood to recommend, my colleagues and I being to focus on as the best marker for whether we've done our real job, which is to give them peace of mind. Now we have to be technically excellent in order to give them peace of mind, but there is more. So the patients can't tell whether we're technically excellent, but they can tell whether we've done the other stuff. So what are the things the patients identified? The number one variable that created a split was confidence in the clinician. Usually a doctor on the outpatient basis, sometimes a nurse practitioner. And you can see if they really have a high degree of confidence in having that Yale logo on their stationery and on their white coats does mean a lot, giving confidence. Then you can see only 1.9% of patients were not in love with their care. So having good people is the most important thing by far. But it is not the only thing, because the next thing that came in on both sides of the tree were how well the patient thought people were working together, the teamwork, the coordination. And you can see that if they thought the teamwork was excellent and they had good people, it was only 1% of people who were not giving a top recommendation. But if the teamwork were anything short of what seemed first rate to the patient, you can see that there's an 11-fold increase in the percentage of patients who are potentially looking for the door. And then you see a variety of forms of empathy and communication. And then you see nothing else. You don't see waiting time, for example, waiting time for an appointment, waiting time during appointment. This is what I mean about patients will cut you slack on the what if you get the how right. If you're delivering care that is empathic, coordinated, and you're showing that you're willing to communicate with the patient. Same thing in the emergency department. This is 1.3 million patients. Tougher crowd, 65% of patients give a top rating versus 85% on the outpatient basis. The number one variable is caring. And as soon as caring was taken up by the model, pain control disappears. The next most important variable was communication. As soon as communication's taken up, waiting time disappears. This is what I mean by disappears. Like if you, and this is again a huge database, 1.3 million ED patients. If you separate them into cells based upon how the patients rated the communication about what was going on, those are the rows going backwards, and then the rows across the front are how long they reported being the ED. You can see if they said the communication was very good, 98% of patients were giving a top recommendation to the emergency department. Now, when we did this analysis, Boston Magazine showed up in my mailbox at home, and it was the best restaurants in Boston issue. And I just started with the first, after 20 restaurants, I got tired of doing it and I gave up. But I just want to see how many of the best restaurants in Boston, when you went on the web to see what percentage of people were giving a top recommendation on the sites where you could actually find that kind of thing. None of them had 98%. None of them had 95%. Some of them were like 80 to 90%. This just shows patients want to love us. They, more so than any other sector, they are ready to give us the benefit of the doubt if we just talk to them. Obviously we have to do more than talk to them, but it shows how important communication is and how little waiting time matters, if we're communicating. Now, I want to emphasize this patient experience stuff is not in conflict with other things that we think of as quality and as performance. This may look like it's a complicated slide, but this was my colleagues at Ganey. We have a bunch of different types of data. If we take hospitals and we talk about and we look at various patient experience variables, like what patients said about the cleanliness, the nursing, and so on and so on. The worst hospitals are the hospitals with the orange dot. That shows the performance for the rate of hospital-acquired conditions for the worst quartile in terms of how patients rated the cleanliness. And the blue dots are the best quartile hospitals as defined by how they rated the cleanliness. And then same thing for nursing and so on and so on. And what you can see for length of stay, readmission, safety, performance, the blue dots are always on the left. That's the better place to be. So there are places that have their act together, and the patients tend to report a better experience. They tend to have lower readmission rates. It's not like there are going to be some people, if you send them home earlier, they're going to be mad. But by and large, the places with better patient experience have better quality performance and of all types, and they're more efficient. They have shorter lengths of stays as well. Um, and the personnel are actually happier at the places that patients are happier. Now, this one just shows you, again, patient experience variables. The best quartile hospitals are the diamonds, and what the set of bars on the right that shows you the interquartile range for the best quartile hospitals and the worst quartile hospitals, and how the physicians, when you roll up all the different measures we have, how the physicians feel about working there. At wherever the patients felt the care was better for all these different dimensions, the doctors also felt that they were happier to be there and it's a better place. And these are actually huge gaps, the differences shown in those bars. I could show you the same kind of figure for nursing. I could show you the same kind of figure for other kinds of personnel. It would be very boring to you if I did, but we have a ton of data behind it. These things go together. So my colleagues and I really feel the big transition that's underway right now is that healthcare is moving from having lots of independent initiatives in outpatient safety, inpatient safety, nurse engagement, doctor engagement, outpatient satisfaction, inpatient satisfaction. And they're moving toward looking at these themes across the continuum. They're looking at safety across the continuum, experience across the continuum. And then the next step is really integrating them and thinking of them. What we really need is a high reliability culture. You have that bottom right-hand triangle where you've got an engaged workforce that's really proud of what they do, and they are reliable in delivering care the way it should be delivered. Those in care that's safe, care that's empathic to patient, care that is technically reliable as well. That's what we're after, and ultimately is having a culture where the workforce is proud and prides itself on being reliable about delivering care the way it should be delivered. That's the real goal here, as opposed to having a bunch of different initiatives. But it's hard to get there because I think, here's where I'm shifting gears to talk about burnout. And so this is like the contribution that I hope my colleagues and I are making to thinking about burnout. Burnout is an issue. I think I'm not going to waste your time by giving you statistics on burnout increasing, which it is, about physician suicide, which is elevated. I'm not going to, you've all heard that before. But instead, what do we do about it? And what I want to give you is a framework for deconstructing burnout. Let me say a little bit about deconstructing complex problems, because this actually is an expertise, a skill, which I hope many of you will develop as time goes forward. Burnout is one of those problems that when you read about it or think about it, you actually feel burned out because it's overwhelming, and it just seems like you feel ineffective. What can you do? It just seems there's no way you can approach it. But burnout is like one of many, many problems that you're going to have in life, which falls in that category of complex problems. There's a framework that people talk about 4 different types of problems. There's obvious problems where what you need to do is obvious and you just do it. There's complicated problems where many people need to do many things, but if they all do their thing, it will be okay. Complex problems are where there are multiple factors that are intertwined, that are driving things, and you can't predict what's going to happen when you do things. The only thing you can predict is that if you just do one thing, if you go searching for a single magic bullet, and I'm going to give physicians more money, I'm going to give them yoga mats, I'm going to speed up the AMR, something like that. If you just do one thing, it won't have any impact with a complex problem because there are multiple factors in play. And so the 4th type of category in that framework is chaotic problems, where you're just trying to get through the next day. You're in a war, you're in the Trump White House and he's saying something new, and you're just saying, what can I say to get through the next half hour? That's the 4th category. But in healthcare, we have a lot of complex problems. And what you do with complex problems, including complex problems with patients, is you break them down, you deconstruct them. You say you into in areas where you might be able to do something, and then you do something in the areas where you can, and then maybe things get better. Like you take care of a really sick patient, you do what you can for the kidneys, you do what you can for the heart, and so on, and maybe your patient makes it through the night, and you do that enough nights, and maybe your patient makes it. So deconstructing burnout, that's what this slide's about. And so you can try to break it down into pieces where you can, you're going to need to do multiple things, and how do you identify them so you can go to bed feeling like you've done what you can and you might be on the right track. So if you break down rewards and stresses into two basic categories, the rewards and stresses that are inherent to taking care of patients, the interactions you have with these human beings who are coming to see you. And then the upper row are the rewards and stresses that are external to taking care of patients. And then the third key component of this deconstruction is there's a fulcrum, on which the balance rests. And you don't want things tipping over to the left, obviously, and that's when people start falling apart. The fulcrum can move. It's different places and different people. But like one of the issues, which we'll talk about in a second, is what will move the fulcrum to the right? Because there's going to be stress in life. And the question is whether you flip out or whether you adjust. So there are three key insights and three key areas of opportunity that come out of this framework. Whoops, I should stay here. Okay, the first insight is that the inherent rewards, the things for taking care of patients, the bottom row, they're intertwined. You cannot separate them. Yeah, it is fantastic being a physician. You do get to feel really proud of what you do sometimes, but it is hard. It's draining taking care of people whose courses are going to be going downhill and their families. It is monotonous, and there's tremendous responsibility. The key insight that they're intertwined, what that means is you cannot try to improve the balance for the issues on the bottom row by decreasing the things on the left. You can't say, oh, just don't take it so seriously when people are miserable, and wall it off when people are feeling horribly and their families are suffering. Don't take the safety stuff so seriously. If you decrease the stuff on the left, you compromise the extent to which people can feel better about these things on the right. So the opportunity number one is building up inherent rewards. The second insight in inherent opportunity is in the top row, the things that are external to taking care of patients. And the key insight is that there's no relationship between the things in the upper right-hand box and the upper left-hand box. You can't give people more money to make them feel okay about difficulty closing records in Epic and ordering a rolling walker with a chair. It's something I just had to do last night and struggled for a little bit. They're going to be furious about those stresses, and you cannot offset that with things on the upper left. Most organizations spend most of their time talking about the upper left, whereas the action is really in the upper right. Let me give you an example of things organizations are doing in the upper right and lower left before I turn to the fulcrum. The one thing organizations shouldn't do is give the message that this burnout stuff, this is about you becoming more resilient. Take your yoga mat, be in the moment and try to unwind, and it's your fault. Instead, the organizations have to give the message that there is a huge systemic challenge, and we get it, and we have to take it on. And so one of my favorite examples that's actually going to be in the New England Journal this Wednesday at 5 o'clock is, 5 o'clock. Hawaii Pacific, they started, I recruited this article, I love it so much. They started a program called GROSS, G-R-O-S-S. It stands for Get Rid of Stupid Stuff. Now, I can tell you that last S did not stand for stuff in its first iteration. It replaced a program called Bright Ideas, where anyone could email in bright ideas for what will make care better. No one emailed them. Well, they would get about 2 a quarter. And then they said, okay, we're going to start GROSS. And when you see things that make no sense, that you can't see how it's making anything better for anyone, tell us, and we're going to look at it and we're going to see, should it go away or should we organize something, another way of doing it? And I mean, none of these things were stupid when they started, but they might have become stupid with time. And like one of them I saw was an ED doc wrote in saying, why are we printing out discharge instructions for the patients and then scanning them and putting them back into the record? And that was because it's from the old days where you would do in those triplicate forms and tear off one form to give it to the patient, and then you put 2 back in the chart. Why would we put 2 back in the chart? I don't know. But so they just created the same process by computer, whereas the Joint Commission says, if you just have a box and you go check off a box saying instructions given to the patient, that's fine as far as we're concerned. So they're little things. They're all little things. They're getting 90 a month, and about a third of them are turning out to be things that can reduce work. They're all little things, but just the fact that they have started a program called GROSS, and it's made everyone laugh, and it shows a commitment to the organization. My Mayo Clinic's program is called CRAP. I can't remember what the letters stand for, but lots of organizations are giving the message, we know there's stupid stuff and we're going after it. And so this GROSS program is spreading fast, and I think after the New England Journal piece tomorrow, I bet you it really goes fast. This one's lower left-hand box. Like at Mayo Clinic, they actually did a randomized trial where half of the physicians in the trial were given 1 hour or more protected time every 2 weeks, and the other half were assigned to be socialized, so that every month they would go out to dinner with a group of 10 physicians, and they had a structure to it where they had to talk about something medical for 10 minutes, but then whatever they want to talk about. And no one was there with a watch to make sure they did it. And after 9 months of intervention, there was no change in burnout in the group that had more protected time. And there was a 15% drop in burnout symptoms in the group that went out to dinner and where people had friends. They talked about their work and so on. And that difference persisted over a year, in part because they continued to go out to dinner. And that was enough for Mayo Clinic to, and now the Brigham is doing it too, basically say, you can form a group, go out to dinner, send the bill to us. Now there's a $20 limit. You can't send alcohol bills, just put $20, for your entree and everything. But actually in Rochester, Minnesota, $20 goes a long way. And so most of the doctors in Mayo have signed up and are doing it. They're just starting it at the Brigham now. And then the third category, resilience, like what moves that fulcrum over so that people don't flip out when the unexpected happens? Because the unexpected happens in healthcare all the time. It's different in different people. I mean, I can tell you from having, seen Charlie as a house officer in those days, his fulcrum was all the way on the right, like nothing would ever get him to complain. And, maybe I only saw him at certain moments. Maybe when I turned the corner, he was going nuts. But for everyone, their fulcrum is movable. I mean, I'm thinking of one of my colleagues where I see patients now. I do primary care in my practice now. And one of my colleagues, whose name I won't mention because Charlie will know, she goes to Guatemala every year and works for 2 weeks in horrible circumstances and comes back completely renewed. And then she practices down the hall from me, and the drawer with guaiac solution is locked, and she starts yelling. She flips out. And I said to her, "Why are you flipping out here and not over there?" And she says, "There, I feel like what I'm doing, I know why I'm doing it." And she says, "Here," she said, "I feel like I'm an RVU machine in a big corporation that's trying to generate Nobel Prizes rather than, valuing what I do." And so that's why I felt like the why of the organization is so critical in determining where the fulcrum is going to be. And the more that, this organization can make clear that it's got a noble why, that makes people feel better about who they are, they draw more pride from the organization and being part of it, it's the smart thing to do. So that leads me, all right, I'm going to skip this stuff. Whoops, I kind of fell a little bit behind here. All right, so let me just turn to this grit part and wrap up and have a little bit of time for discussion. Angela, my cousin, she wrote this book a couple of years ago about grit. Let me ask, how many of you know this book or know Angela's work on grit? Okay, so a chunk of you, but not a big chunk. So Angela was very interested in she after college, she worked as a consultant, but then she didn't find it meaningful. She started being a school teacher in the New York City system. And she became obsessed with the question, why do some kids hang in there and make it and other kids don't? And it didn't seem to be IQ. It didn't seem to be their home situation. But she wanted to understand what was going on psychologically with them. And she went back to grad school at NYU. And while she was getting her PhD in psychology, she got the chance to go to West Point and try to help them understand which cadets are going to drop out. You know, they have a 20% dropout rate, and besides it basically being, you know, horribly destructive to the young people who can't make it and they feel like failures, it's also a big investment for the United States taxpayer that's been lost when someone drops out. So Angela came up with the grit scale, like a 10-question instrument. You express your agreement with various statements. That turned out to be a very good predictor for who would drop out. And so that's when she started a whole bunch of research on grit, like where people have, you know, passion and perseverance. They feel passionate about something and they hang in there until they try to get better over years and decades. You know, Roger Federer, you know, arguably top tennis player in the world, continues to have a coach and continues to feel like he's got to get better. Even if he's number one. He may not be number one now, but he probably will be again. So Angela and I wrote this article about healthcare grit and organizational grit in the last Harvard Business Review, because the things I put in this slide, you know, healthcare in the past has thrived based upon having gritty individuals. You know, it attracted physicians who would pride themselves on getting up whenever they were called and coming in and seeing their patient, and nurses who wouldn't get unsettled when patients would be falling apart. And we still need gritty individuals, but you don't take care of patients by yourself anymore. You know, care is delivered by teams and organizations. So we were interested in the question about, you know, okay, what does it take to have a gritty team? You know, we know gritty teams exist. We can see examples of really great teams. Like, frankly, that breast cancer screening team, that's a gritty team. They've got a cause, that they've got a passion for something, and they have been working and making things better and better and better over 12 years now. Just having an organization just attracts gritty people. And I mean, I think Charlie and I trained at the Brigham. I think the Brigham is a place that attracts gritty people. But that's not the same as actually being a gritty organization itself, where the organization is trying to get better as well. So that's what Angela and I, you know, plunged into in this article that's in the last issue of Harvard Business Review, not the current one, on organizational grit. Now, I know, you know, I make these slides myself, so they're not that beautiful or legible, but I want to say that for those three levels of organization, like the individual, for teams, and the overall organizational culture, what Angela and I came down to is basically there are four key ingredients. I'm just going to mention these, and then I think we'll break for questions. The first ingredient is having a goal hierarchy. Now, and I sort of just cut and paste these figures from the paper into here. I know that I apologize that they're not legible, but this is like for an individual, like a cardiologist. This is like for an overall organization. And a goal hierarchy is where, you've got lower level goals, which are basically like your to-do list. They're the things you have to do. But if you've got a clear goal hierarchy, you can see you can understand how those things track up to a mid-level goal, and those mid-level goals track up to a high-level goal. That basically is the why from that Simon Sinek framework. You know, that you want to ease the suffering of patients. You want to, and you know, I just did a cardiologist. you know, on my example on the left, and like an overall organization on the right. And I think that basically the mid-level goals are the how and the low-level goals are the what. And you know, if you've got a clear goal hierarchy where you can see how the things that you're being asked to do clearly track up to something that makes you feel proud, the why that makes you attracted you to this place, to this work, and so on, that's something that's helpful for people having grit and teams having grit. The second is a growth mindset. So a growth mindset is, you know, this comes from the psychologist Stanford, Carol Dweck. She popularized this term. Where, you know, growth mindset is where you think you can get better, you must get better. You know, things are not fixed. You're not doomed to being the way you are. You know, that, you know, the drive to improve is something that you have to do. The third is, you know, a resilience orientation where you actually, you know, there are lots of places in healthcare that never want to acknowledge setbacks. You know, they would, they jump through hoops to sort of deny that anything bad has happened. Whereas there are other organizations that acknowledge them and say, we're going to learn from this and we're going to, you know, and we're going to get better. I mean, I was just visiting an organization that had a complete disaster in the rollout of, in the consolidation of Epic platforms, where it simply stopped working in one major region for them. And there are a lot of places that would have just sort of been papering things over and stuff. But the CEO went there and she met with, you know, all the physicians and nurses, and she apologized and for it. And she said she knew it was, you know, I thought that was something much healthier than not acknowledging it. And then the fourth is you strengthen the group identity, you know, between individuals and the group they belong to. I have some slides on, you know, some of these nuances of building grit at these various levels. But let me just close by saying, I do think there's a path forward for these two types of issues, patient-centered care and burnout. I think there's good news. You know, the major factors that are driving likelihood to recommend for patients, they are things within our control. They are the how. It's not the what, it's the how. And they are the same across all settings of care. I didn't show you every setting of care analyses, but believe me, they're all the same. They want coordination, they want empathy, they want communication. It takes good personnel and it takes social capital. You know, working together to improve coordination of care, social norms, where, you know, you're not, you know, you're going to feel uncomfortable if you're not working to make care coordinated and you're not showing empathy and good communication. And I think the best news is I think these drivers are completely consistent with the professional values that bring people to healthcare in general. And that's why I'm confident that there is a path forward that takes on both burnout and what patients are going through. And I think that for a lot of you out here, you're going to find this kind of work very enriching as time goes by. So with that, let me stop and get your questions and comments and reactions to how this work might be relevant here.